Thanks everybody for sticking around. Long day, but a great day. Thank you to Dr. May for inviting us to present a few cases. I'm going to start with a young woman. You know, we all have these patients that kind of get under our skin, and most days we can sort of leave things at the office, but there's always those few patients in our career that kind of get under our skin and stick with us. I would have to say the case that I'm going to present, for my case, this is a young woman that still kind of I think about, and you know, she's one of those patients that kind of got under my skin a bit. I think about her a lot. So I've gotten some honorariums from AstraZeneca and Merck, and probably I should add more recently some travel reimbursement from Minogue. At the end of my session, I'd like you to be able to describe the pathophysiology and clinical course of a patient with small cell ovarian cancer, hypercalcemic type, to demonstrate an understanding of the role of family history with these types of tumors, and to outline a reasonable management approach for patients with small cell ovarian cancer. So this was way back, 2014. 30-year-old presented. She was referred to a general surgeon through a non-tertiary emergency room. For those of you that don't know about the geography of Newfoundland, where I practice, there's only one tertiary care facility in the province and several secondary facilities, and some of the patients are, you know, from 8 to 10 hours away. So this 30-year-old presented with intermittent abdominal cramping, bloating, change in bowel habits, diarrhea, constipation, had some bright red bleeding, not just with wiping, but also on her stool. She had seen the general surgeon, and on the emerged record, it said functional bowel disease, whatever that particularly is. She was given some dietary advice, and she was booked for a colonoscopy. Can everybody hear me okay? So then in December, a few weeks later, she re-presented to the emergency department with increasing abdominal pain and distension. And at that point on exam, she had a huge mass, palpable well above the umbilicus. This is one of the axial shots on the CT at the time of that presentation. So we decided we don't have a pointer, do we? So you can see, you know, mixed attenuation, solid and cystic, large abdominal mass occupying most of this young woman's pelvis. On the sagittal views, you can get a good look at it there as well. Very mixed attenuation. The CT reported a large heterogeneous mass arising from the right ovary, no fluid, no evidence of omental caking or peritoneal studding, no evidence of any enlarged pelvic or periaortic nodes, and the chest was reported as clear. She was referred to the local gynecologist there. They had done some preliminary blood work. The CA 125 was 369. So this woman had presented to, you know, one of those tertiary, secondary centers. So as it's not unusual for us to sort of get calls in the middle of the night, what do you think of this? Or so this was one of these situations where we get a call, and the patient's really uncomfortable. The gynecologist reports an enlarged, complex but mobile mass. The patient herself worked at that facility and was keen. She had a young child. She wanted to be treated locally, and it was her second presentation. And the plan was at that time decided that she would, the gynecologist with the general surgeon, would take the ovary out and do an omental wash and omentectomy and a wash and peritoneal studdings and have a good look around. And that was the plan. So she was a healthy 30-year-old. She had absolutely nothing wrong with her. She had one cesarean section. The only interesting thing of note on her family history is that her mom had died of a breast cancer at 47. There were no other cancers in the family. The mom didn't have any genetic testing done at that time. And like I said, this young girl worked as a dietitian in that local hospital. Non-smoker, non-drinker, had good social supports, had a partner. So at the time of surgery, the gynecologist did the surgery with the general surgeon. They did a wash. That's supposed to be RSO, not LSO, sorry. Infracolic omentectomy and a bunch of peritoneal biopsies. Basically, everything looked okay grossly in the belly. There was a large right-sided complex ovary, but it came out without spilling. They did an omentectomy, they took out the appendix, they did peritoneal biopsies. The intraoperative notes that the opposite ovary had a normal appearance. But when I spoke with the gynecologist after, she had actually sampled a little flimsy, what she described as flimsy surface excrescence on the other ovary. So the pathology came back from the ovary as a small cell carcinoma, hypercalcemic type. There were a bunch of biopsies done. They were all positive for malignancy. The omentum was grossly positive. They did an appendectomy at the time. I'm not quite sure why, except perhaps they might have done it as part of their staging, or maybe they were worried about a mucinous component, as based on how it looked. I'm not sure. The appendix itself was negative, but basically all the other biopsies were positive for small cell carcinoma, hypercalcemic type. So it involved the right ovary predominantly. The ovary was 17.5 centimeters. The surface of the other ovary was reported as positive. The omentum was involved, and the peritoneum was involved. So she was staged as 3A due to the microscopic involvement of the omentum. So the pathology, as would be pretty standard for very rare things like this, it was sent out to a gynae pathologist at a tertiary facility, and this was their path review, consistent with the same small cell carcinoma. So she got referred to Gynecology. It was about 4 weeks post-op. We hadn't done the surgery, so we ordered a CAT scan just to make sure everything looked okay in the belly before coming up with a treatment plan. And the CT at 4 weeks showed a lesion in the lateral segment of the left hepatic lobe. Not that big, but about 1.5 by 1.5. And some lesions within the posterior cul-de-sac. Again, not that big, but 4.5 by 2.5. The CA-125 at that time was 21. It had been 369. This was her liver lesion at the time. This was around 4 weeks post-op. And this was some sort of cystic area within the pelvis that the radiologist had commented on. So here's where we pause. So she's 30, she has one child. She had a fertility-sparing staging procedure, albeit not by a gynecologist. And she's 4 weeks out, and she has suspicion of something in her liver and something in her pelvis. And I think the question will come up now. Go back. Okay. Can't hear you.
The question is on the phone.
Okay. It doesn't also come up here, though?
Okay.
Well, I don't have it coming up. Do you guys have the questions coming up on the phone? Yeah. Maybe pull up your phone.
Yeah.
It'll say, if I recall, it will say, do nothing, go home with your 4-year-old, reoperate, chemotherapy. Forget the other questions. So do you move forward or do I? Do you move forward or do I?
No, I do.
Okay. Okay, whenever you're ready, you can move forward.
That's a bit confusing.
So the question was sort of polling the audience in terms of what people would do. Some people said complete the staging surgery, take out the other ovary and the uterus. Some people suggested chemotherapy. Some people suggested surgery and chemotherapy, chemotherapy and surgery, and then thankfully nobody said go home and enjoy your 4-year-old. So there's going to be another question coming. So this question is for those of you who suggested chemotherapy. Oh, there you go. Pretty quick. Okay. So majority chose cis and etoposide. Some chose.
I think it's still coming.
Oh, still coming. Sorry.
Sorry.
Yeah.
Give it away.
Still coming in. Ideas are still coming. Okay. So most people chose some sort of chemotherapy. It's interesting. I'm going to talk a little bit about nivolumab. I should have said I am going to talk about one off-label indication. It will be nivolumab. Should have said that at the beginning. There was a lot of debate. I phoned a lot of friends in terms of getting advice about what to do. I'm from a small center. I hadn't treated a patient who had small cell carcinoma of the ovary with hypercalcemia, and there were a wide range of suggestions, as we can see here. It makes me feel a little reassured that that we at our center also decided to proceed with cis and etoposide.
Can you answer the first question? Did you take her back for surgery or did you give her chemotherapy?
I gave her chemotherapy. I gave her cis and etoposide, yeah, at that time. So like I said, we talked about her locally at our Tumour Board. I had discussed with several Canadian colleagues. I had reached out to MD Anderson because at that time they had published a series of 7 patients with small cell carcinoma of the ovary. We had discussed at MD Anderson, an expanded chemotherapy regimen, but we decided on cis etoposide at the end of the day. So she got 3 cycles of cis etoposide. She was a healthy 30-year-old. And I can tell you she really, really struggled, for whatever reason, getting through those 3 cycles. So she had a good response. The liver area basically went away. If that was ever a positive disease, the pelvic disease regressed. And she had repeat surgery with a hysterectomy, removal of the other ovary, and basically there was very little residual disease at the time, but in the pouch of Douglas she did have a little bit of sort of vesicular, still residual disease along the uterosacral ligament, which we took off, and that second surgery was felt to be optimal in terms of the surgical approach. But everything still showed small cell carcinoma. The left parametria had small cell, the right parametria had small cell. There were peritoneal biopsies that showed small cell. The little vesicular stuff that I took off the uterosacral ligament, that was still all small cell carcinoma. So these are just some gross pictures from pathology. You can see the stroma and the impressive tumor adjacent. It's too bad we don't have a pointer, but you can appreciate the extensive sort of small cells throughout with scant cytoplasm and the areas of increased mitoses. Our pathologists, in an effort to determine Müllerian tract or not, use WT1s. You can see the positivity in the sort of darker cream-colored WT1 positivity. In terms of this being an epithelial cancer, I guess they were trying to figure that out. It was very, very focally pan-keratin positive, so that stained very poorly. So in keeping with this probably not being an epithelial primary. And then the Ki-67, just sort of a very, very, very active tumor with very high proliferation rate. And here's the probably little excrescence on the opposite ovary, which was still there after 3 cycles of cisotopicide. There was a little excrescence on that other ovary. So she had 2 more cycles of cisotopicide, very difficult course, profound fatigue and nausea. She presented at one point after the 2 cycles of cisotopicide to the emergency department with acute shortness of breath and had a CT pulmonary angiogram to rule out a pulmonary embolus, which was negative for a PE, but there was a question of some areas in her spleen, highly suspicious for metastatic disease. At this time, her CA-125 was 10. She was not symptomatic of anything except the shortness of breath. She wasn't having any abdominal pain, and she was physically wiped out. So her functional status was poor. She basically couldn't get out of bed. Her quality of life was terrible, and she needed a break. So we just basically decided they were going to re-image these splenic areas. They were nonspecific but suspicious for recurrent disease. We didn't have a PET scan at that time. So this is 2015. So we're now about 3 months after chemo. Before she represented for her booked repeat imaging, she actually presented with vaginal bleeding. And she had a firm, palpable mass at the top of the vagina. At this point, in terms of management planning, I actually sent her to Halifax to have a PET just to see if there was anything else that was FDG avid. To figure out where to go from here. And all the stuff in the pelvis lit up like a Christmas tree, and she had several other areas of PET positivity. She had a query right lung lesion, but it was not FDG avid. And it was only at this point that she became hypercalcemic. She hadn't been hypercalcemic before that. So I was, calling my friends again. This was about 6 months later now. MD Anderson had a few more patients that they had treated with the vinblastine, cisplatin, cyclophosphamide, adriamycin, etoposide. She was 30, and she had, she was feeling okay. She wanted to be as aggressive as possible. So she got 1 cycle of that. She didn't leave hospital for, I would say, a month. It was crazy. Profound fatigue, nausea, myelosuppression. Platelets took, almost a couple of months to recover. So to say that didn't go well was an understatement. And she was in hospital. This wasn't chemotherapy at a peripheral site. She had all the resources of a well-trained chemo inpatient unit. Next question. So she's had 2 surgeries. She's had 5 cycles with cisplatin and etoposide. And then she got the 1 cycle of the expanded regimen. She has big pelvic tumor now, bleeding. So she got under my skin. You're going to find out how what an impact she had on the radiation oncologist when I get to the end of this case, because she got radiation about 5 times. I think people are done now. About 54 people here. Still coming. So that's exactly what she got. She got radiation at that time to the pelvis, and didn't get any further chemotherapy at this time. Yeah. So I jumped ahead 1. So the question was, if any of you had opted for chemotherapy at that time, which chemo drugs would you have chosen? Initial chemo, this is less than a year. Yeah. This is August 2015. Her presentation was December. So a lot of people are talking about nivolumab, and we were thinking about that at the time, but it was 2015. We didn't have access to nivolumab at that time. I'm just going to move on to the next slide if we can. So between October 2016 and December 2017, she basically got palliative RADs 4 times. I just chose some representative axial CTs to show you sort of how this course went. She got palliative RADs, and then she eventually became very symptomatic, I think, with hepatic capsular distension. She got palliative RADs there, and she got RADs to the spleen. She got RADs several times. And then in the midst of all that, we also were, throwing the book at this patient, basically. She got 2 cycles of topotecan IV with ongoing pain. She did tolerate 2 cycles of topotecan, and then she was done. So we were trying, by this time it's 2016, we made a bunch of, requests to try to get nivolumab. She tried to buy it through her insurer. We, were advocating for the insurer. There was like a community support GoFundMe page to try to raise money for this woman to get nivolumab. We do have access for off-label medications at our center. We have a process of rapid special access. But the consensus at that time was that there just wasn't enough safety data to support nivolumab. So it carried on. She got more palliative RADs for tumor extruding through the vagina, and then eventually, April 2017, presented in a pain crisis. And, she died of this disease basically 4 days later at 33. So there's going to be a little bit of opportunity. I just want to talk to you a little bit about small cell ovarian cancer in a few coming slides. The crane is the symbol for small cell ovarian cancer, in case any of you didn't know. My son was into origami at that time and made this little crane, and now he's only into girls, so he's not interested in origami anymore. So these types of tumors were originally described in 1982. A lot of us would remember Robert Scully as sort of reading about a lot of his work in our textbooks. This is a group from Harvard, and they described these tumors. And then as more cases came through, they kept adding to the body of literature about small cell carcinomas. So it is a really rare disease. There are, to date, based on what I could find, less than 300 cases reported in the literature. These affect and impact young women. Their 5-year survival is less than 10%. 1 year survival is around 50%. So the next question. I'm kind of curious. We now have our second patient on the go at 22 with a small cell ovarian cancer hypercalcemic type, but I'm curious about the bigger centers and how much experience they've had. Yep. Yeah, I'm coming to that. Yeah. Yeah, so it's interesting. When I called around, I called 4 or 5 Canadian centers. Most of the people I spoke with had no experience with this subtype of tumor. So basically, none of us have that much experience. Bigger centers probably have had maybe 5 or 6 patients, and most centers less than 5, and half of you, none, so that's interesting. Okay. Next question. So I kind of hinted at this a little bit in terms of what's the where do we think this is coming from? Is it epithelial? Is it germ cell? Is it sex cord stromal? And so, does anybody have a sense of where these tumors come from? There's been a lot of work trying to sort this out. There actually is a case report of a small cell within teratoma, but the body of literature now is supporting the fact that these tumors are rhabdoid related, and a lot of you have already heard about that. So I'm not sure if everybody has responded yet, but they're definitely not germ cell, they're definitely not sex cord stromal, they're not epithelial, and they're most, by histology, they are most like rhabdoid tumors. If I can move on. It's a bit finicky. So as I said, these were originally reported as rhabdomyosarcomatoid variant of Wilms tumor, but now Dr. Folks in Montreal is doing most of the papers have Dr. Folks associated with this consortium of work on small cell cancers, and obviously Dr. Huntsman in BC. So the next question. Which germline or somatic mutations are related to small cell carcinoma of the ovary, do you think? So even though you haven't seen small cell ovarian cancers, most of you have already heard about the association with the SMARCA4 mutation, so that's awesome. So in 2014, this group of, and Dr. Huntsman's sort of affiliate, like I said, there seems to be an international consortium of the same names come up on a lot of the papers. So this definitely displays inactivating germline and somatic mutations in SMARCA4 proteins. So this is that protein complex associated with BRG1 that's associated with the switch and the sucrose factor complexes that are regulating gene activity, DNA synthesis, and that's as complicated as I'm going to get into that. This is a bit of a busy slide. I wish I had a pointer. Just to point out to you, in C, the first and second columns will be the positive and negative controls. And then the bin, I can't read it here now with my 50-year-old eyes, but I think it's like bin 67 or something. That's the small cell ovarian cancer. And then all the others are, serous, endometrioid, clear cell, dysgerminoma. They all express, but clearly the small cell cancers do not express. And then when you look at the immunohistochemistry, the third from the top that's a negative and positive control across the top, and then the small cell demonstrating complete lack of expression in the immune profile. So again, a busy slide, but you'll see that there's a whole bunch of different mutations identified, and some of them are somatic and some of them are germ mutations, but in terms of the protein expression, it's negative, it's absent throughout. So whether or not this is linked in families, we're not sure. It's very interesting that this girl had a mother that died of breast cancer at such a young age. There are a couple of families now identified as having a familial association with the small cell ovarian cancers. Of course, the penetrance of these mutations is unknown. Really important to send all these patients to genetics, and the literature would support the fact that there's really dramatic similarities between the rhabdoid tumors and these small cell ovarian cancers. So our patient, her somatic testing was positive, but her germ line testing was normal. So MD Anderson probably has one of the largest series now reported. This was published in 2017. And they actually had one girl that survived this disease and actually went on to have a baby, which is interesting. You can tell from the demographics that these are young women. There is a bit of a preponderance for right-sided tumors. I don't know why. Our patient had a right-sided tumor. Nulliparity doesn't seem to be related. Obviously, a lot of these women present with advanced stages, kind of like epithelial ovarian cancers. And it's a bit of a, mishmash in terms of when they looked at these 47 patients who got what chemotherapies. So some got CIS, some got CPAE, some got the VPB that I tried with my patient, the 5-drug regimen. And I haven't included all the slides, but I would say to you, on balance, they see trending in terms of women doing better in terms of their survival if they get the combination of the vinblastine, cisplatin, cyclophosphamide, bleomycin, doxorubicin, and etoposide first. My patient wouldn't have tolerated that, I think, because probably her bone marrow might have already been wiped out. But whether or not she would have tolerated that up front, I'm not sure. The other thing in this series of 47 patients, they do see trending towards women who got adjuvant radiotherapy, having somewhat of an improved survival. So this would be the overall survival. It looks kind of bleak, but there are some patients that have responded up to more than 60 months out. Again, most of the stage 3s have an overall survival months of about 10. They did have, interestingly, one patient that had a stem cell transplant. She had advanced disease, surgical debulking, induction chemo, and then got cyclophosphamide, adriamycin, vincristine, and stem cell transplant. She didn't do well. There is a series of patients that have gotten transplants. And actually, this looks kind of interesting. Their median follow-up was 37 months, and they had overall survival at 1 and 3 years, was 58% and 49% respectively. So I think this is an interesting avenue that really requires more research. Of course, this is a very rare tumor. It's going to be really difficult to get any significant numbers with these tumors. And the other big thing is that there is definitely an active immune microenvironment for small cell carcinoma of the ovary. And a lot of you chose nivolumab, so I think you've already heard about, the PD-L1 and PD-1 opportunities for maybe treating these tumors. So just to remind you that if you block the PD-1 or PD-L1, you allow the T cells to resume their killing impacts. This is, again, a totally busy slide, but I just want you to look in the top far corner that the PD-L1 is really, well demonstrated in these. This was three cases of small cell tumors. So definitely, this is a group out of Memorial Sloan Kettering, and they have done a lot of the immune work with pembro and nivolumab, and they have, they really support the fact that these are immunogenic tumors, and they exhibit biologically significant levels of T cell infiltration and PD-L1 expression, so that's it. The lead author from this paper, they had 4 patients in that paper who actually, it was a consortium, I think, with Brazil and Memorial Sloan Kettering, and the author didn't know the outcome of the 4 patients. They had 3 treated with nivolumab and 1 with pembro. At the time of the publication, 2017, the 4 women were well, but they have a few patients currently on nivolumab and pembro, and anecdotally, he said they've had a few complete responders, but they've also had a few recurrences, and as we have another patient now, the question we were posing was, what is your plan for nivolumab and how long will you treat patients with nivolumab? And their plan would be based on other disease sites to do it for a year if the patient tolerates or they don't demonstrate disease progression. So this, I think, is about my last slide. This is a Chinese group that's come up with sort of a look at small cell carcinoma of the ovary. in terms of the molecular findings and how you might manage a patient. So if you suspect a small cell ovarian cancer and the BRG immune staining demonstrate a loss or SMARCA loss, then you can be reassured that you've got a SMARCA mutation. And then at that point, you can do the somatic testing or the germline testing. These would be in women that had fertility-sparing surgeries initially, which is what most of these patients have. This group has recommended that if the germline mutation is not there, then you can test the family members and leave the ovary. But if they do have a germline mutation, then you should go back and take out the contralateral ovary and obviously test the patients. And obviously they advocate for everybody getting their tumors tested for the SMARCA mutation. So I'd welcome comments. An aggressive disease, obviously SMARCA is where the money, where it's at. There may be a familial component, it's certainly looking that way. As I mentioned, one of the multi-agent regimens from MD Anderson survived her disease and actually went on to have a baby. She had conservation of uterus and other ovary. There's going to be a lot more work with nivolumab coming, and it's interesting about the bone marrow studies. So there's a small series, obviously, of only about 50 patients, but that's very interesting work. And there's a really, really good online support, kind of geared towards patients, but there's a really good section on that website for physicians and gynecologists as well. So I would really like some comments. If I had to do it all over again, what would I do? I'm sure that question's coming. Probably would have put her on a plane and brought her in. I'm not sure if it would have made any difference if Oncology did the surgery. You know, we always say debulking is better if oncologists do it, but she didn't have a neomental disease. She had a good staging, I think, by all intents and purposes. And Diane?
Can you review the literature? How often is the contralateral ovary involved?
Not that often.
The ones I've seen,
Yeah.
it's usually
Yeah.
one ovary and everywhere else.
That's right, yeah. It's not that often. I think it's around 10%.
Yeah, I'm not sure there's a whole lot of point in taking out the other ovary.
Yeah.
So I had a patient who was 30 years old 7 years ago and who presented, she had one child, 1 year old, 1.5 year old, unilateral mass, 7 centimeter and some ascites. So we operated on her, we talked about fertility sparing. I took out one ovary and did a staging for her. And her pelvic and paraortic lymph node came positive, so she was advanced stage. She was small cell carcinoma. I did not do any genetic. I had no knowledge of that at that time.
Mm-hmm.
I think I kind of talked about few people around. I'm not too sure, can't remember anything. But we right away, she had one ovary left and a uterus left. Based on aggressive nature, we decided to treat her with chemotherapy and offered her cisplatin and etoposide.
Mm-hmm.
While she was on 3rd cycle of chemotherapy, she complained of lots of abdominal pain, discomfort. We did a CT scan and she has mediastinal lymphadenopathy, significant. And so we decided there's no use of taking back for surgery. We continued chemotherapy. I'm just trying to think in my mind, and I think we may have discussed few things. By 4th cycle, she presented with vaginal bleeding. When I examined her, she had a big mass in her pelvis, the way you are kind of describing.
Mm-hmm.
And she was bleeding from there. And anyway, she ended up with pseudomembranous colitis. She ended up with VTE, PE. And basically, by the time her daughter was like 2 years old, she was 3.5 to 6 months in her course of treatment. She never came off any chemotherapy because she continued to progress. And by 6 or 9 months, basically, she passed away. So her husband comes for ovarian cancer walk, and he met me a couple of years later, and he told me he has remarried, has another partner, he's thinking to have another family. And he wanted all the information about his wife and things so that he can think about, he has a daughter who was 2 years old at that time. Mm-hmm. So I don't know what happened now, and now I can't remember. I think I kind of remember her name in my head. But yeah, so that was quite a bit, as you said, she's still under your skin.
Yeah.
That patient is still under my skin.
Yeah.
And it's like 7-8 years ago, but she died within 6 months all these things?
So the 22-year-old that we have now under our care, we could make a more reasonable argument for nivolumab. So she is 22, and she just had the one ovary out in staging, and she had some positive pelvic disease, and she had a CR on nivolumab. She continues on nivolumab. She's about 7 months, so we'll see. Does anybody? I'm sorry, I'm taking up Anna's time. Does anybody else have any comments or advice or?
I have a question. Do you know if they've looked at SMARCA before for small cell cervix or anything?
I do not know. I do recall a reading that this type of small cell ovarian cancer is nothing like, for example, small cell of the lung. It's a completely different entity. I pretty well looked at most of the literature about small cell, but I was searching ovary, so I can't say for sure if that work is done in other gynecological tumors. Thanks.
Sure. Thank you. Thank you for that great and interesting and tragic discussion on that patient. I've got something a little bit more run-of-the-mill and potentially positive. I do realize I'm standing between you and a night at the casino. So we'll try and make this quick. I know. 15 minutes. All right, let's skip through this and this. I was a resident at this point, so this is not my case. But this is a 56-year-old who presents with a history of postmenopausal bleeding. She has a thickened ultrasound endometrial lining and a simple cyst in her right ovary, as well as a normal left ovary. On an endometrial biopsy, it's an endometrial adenocarcinoma, but it's ungraded because of crush artifact. So she's seen pretty quickly in a gynae consult. She has an unremarkable pelvic exam, no real evidence of metastatic disease, and we repeat an endometrial biopsy, which comes back as a grade 2, normal tumor markers. She's otherwise healthy, no concerns. But we do a CT pre-op, and she's got a small hypoattenuating lesion in the right lobe of the liver when metastatic disease can't be excluded. There's prominent left periaortic lymph nodes and a borderline left iliac chain lymph node. And once again, metastatic disease has not been excluded. And bulkiness to the cervix and dilation of the endometrial canal and a cystic lesion in the right ovary. So, as we all know, we know that an endometrial biopsy is great at diagnosing cancer, but there's a huge discrepancy between a final histology and a biopsy. And here, this is an older study, but the highest correlation here is grade 1s, and it's 64%. So if you have a grade 2 on a preoperative biopsy, there's a 48% chance it's actually going to be a grade 2 at the end. So my question to you is, you should have this on your phone. Nope, I'm still in small cell. So based on the findings of the CT, this is kind of fun. All right, I'll give it a few more seconds. Okay. Yeah, no, it's hard to gauge. So it looks like most people are thinking about changing to a laparotomy. and with a plan to debulk to microscopic. And that's what, did I skip a slide? Sorry, yeah. So on March 1st, 2011, she had a midline laparotomy, a THBSO, bilateral pelvics and periodic lymph nodes up to the left renal artery. Periodic nodes were grossly enlarged, and a frozen section was done. There's no, which showed metastatic carcinoma and no ascites, and everything was microscopically debulked. So pathology came back grade 3, endometrioid adenocarcinoma, invading more than 50% of the myometrium, with a small area of serosal involvement and extensive LVSI. The left ovary is positive, and almost all of the lymph nodes, except one right pelvic lymph node, are positive for metastatic disease, and 5 out of 5 periodic lymph nodes are positive. So she's a stage 3C2, grade 3 endometrioid adenocarcinoma of the endometrium, and falls right into that category of, we don't know what to do with these patients exactly. So if we're looking at survival, in terms of, in stage 3Cs, with respect to the amount of periodic nodes, if they've got more than two or more periodic nodes that are positive, their 5-year survival drops to 20%. And then if you combine this with LVSI, and in this case, she had extensive LVSI, but it's still 20%. So the number of positive periodic nodes, and in her case, she had 5, is quite prognostic. And once again, we're at 20% 5-year survival. So we'll go on to your next question.
How old is she now?
Early 60s. Yep. Thank you. It's suspicious, but we'll get to more imaging. So I was really curious to see what kind of the division here would be in terms of where we go from here. And most people are talking about chemo and RADs with periodic chimney. I think we're done. We can move forward. Thanks. So when we look at the NCCN guidelines, and these are the latest 2019 guidelines, it's a lot of plus or minus. We have systemic therapy, plus or minus external beam. There's no good, we don't have a good algorithm for primary treatment in these patients. So our Tumour Board in 2011 recommended 6 cycles of carboplatin paclitaxel. The patient ended up receiving, there was a carbo shortage, and so she had 1 cycle of carbo followed by 2 cycles of cis, and then 3 more cycles of carbo. And she had some neuropathy, but otherwise tolerated it well. And then when we're looking at chemo versus RADs for stage 3-4, this is a Cochrane database review. So sorry, it's a little bit blurry. I apologize. But in the stage 3 for progression-free survival, it's not chemo is favored, but it's not statistically significant. But when you combine stage 4 and stage 3-4, it's just statistically significant. Patients with chemo do better. When you're looking at overall survival, again, stage 3 and stage 4 separated are not statistically significant, but they are when combined. And then this was presented just as a G209 abstract, and it was comparing carbotaxel versus doxotaxel and cisplatin, and the hazard ratios for PFS and OS were about the same, and so carboplatin and Taxol was not inferior, and so we went along with that. Now, PORTEC-3 comes out after this case, but it's an interesting review in this context because this is kind of the subgroup where this patient might fall into it. And we're looking, and everybody recommended chemo RADs. So should we be doing that? And in terms of overall survival, there is no difference of chemo RADs versus Am I being cut off? I might be being cut off. Okay.
It's just a bunch of actors, fans outside the door.
And when we're looking at failure-free survival, the 5-year failure-free survival, there's an advantage to chemo-rads. So should we have done this in this patient? We'll find out. Again, in the failure-free survival, the interesting points to note that are actually significant are the serous and clear cell subtypes, the patients who have extensive LVSI, as well as the over 70-year-olds definitely benefit from chemo-rads, even though the entire total is better with chemo-rads. And when it comes to the overall survival, it's only really the 70 above, which we all already kind of know from PORTEC 1 and 2, they do worse. And so chemo-rads are better. So she had a completion CT after 6 cycles, and there's no residual lymphadenopathy in the abdomen or pelvis. So no residual lymphadenopathy. She has a low attenuation cystic structure in the distal right external iliac node chain, but probably just a lymphocele. And that sub-centimeter hypodense lesion in the hepatic segment is still smaller, but less well-defined. All right, 3-month follow-up. No evidence of pulmonary mets, 2 hypodense lesions in the liver, and new lymphadenopathy is seen on the left periaortic region, just inferior to the left renal vessels in keeping with metastatic lymphadenopathy. So discussion with the patient, what do? We decide for more re-imaging a month later with the CT PET, and it's further enlarged. So we've got a diagnosis. This is metastatic disease in the left periaortic lymph nodes. But there are no other sites of regional or distant metastatic disease. So Sarah, to come to your question about the liver mets, they're not lighting up on PET. I don't know if I can go back. 1.6 by 1.7 was the original one. All right, so everybody thinks that we should have done radiotherapy in the first line setting. Now we're too late. Sorry?
Why did she have the imaging done?
So she had just because of the larger debulk, she had imaging post and then decided to follow up with imaging 3 months later. All right, so radiotherapy. So we know this is in the first line setting, but in the context of endometrial cancer, there's a little bit less information out there about what survival is based on the extent of cytoreduction. So this is an older study, again, 97, and at that point they deemed optimal debulking as less or equal to 2 centimeters. So group 1 is less or equal to 2 centimeters, group 2 is greater than 2 centimeters, and group 3 is peritoneal carcinomatosis, undebulkable. And this is their survival in stage 4 endometrial cancer. So the SVD, not spontaneous vaginal delivery, and O are optimal debulking, and we're looking at versus the S and the U, which are undebulkable and suboptimal debulk. So there's a huge difference in survival from 31%, 5-year survival, or a median survival, 31% versus 12% in the suboptimal and 3% in the undebulk, or 3 months, sorry. Those are months, not percentages, in the undebulkable. So we're Calgary. We took her to the OR. So she went to the operating room, and her right periaortic lymph nodes were debulked. There was a resection of the left retroperitoneal tumor all the way to beneath the left renal artery, and there was no residual disease. And the pathology, again, showed metastatic, poorly differentiated adenocarcinoma. So then we followed that up with a radiation oncology consult, and she got 4,000 centigrades in 20 fraction and completed that at the end of March. She unfortunately did have radiation enteritis and radiation cystitis and was admitted for short-term TPN, and symptoms gradually improved. So what would you do next? All right. So it's looking like most people observe. So she came back to clinic and we, oops, I didn't touch anything. We offered her some more chemotherapy. So of note, she had significant peripheral neuropathy from her prior treatment. And when we look at the literature in terms of what should be given or what could be given, the paclitaxel is often the chemotherapeutic agent that has consistently produced the best results with patients with prior chemotherapy. But unfortunately, due to her neuropathy, we weren't able to give it. But doxorubicin and cisplatin also do a pretty good job. They have a response rate. So the response rate with Taxol is 57% versus 34% with just doxorubicin and cis, but given her neuropathy, we didn't give it to her. So she, and I'm not sure why, I think the patient may have requested this, but she wanted a PET, and so we followed her up with PET subsequently, but she got one just after she started her chemo. And there was partial metabolic and anatomic response to the radiation, but it was still present. After 5 cycles, she had another one, and there was still prominent FTG uptake, and no new FTG avid disease was noted elsewhere. We followed her up on the next 3 months. It's still there, but it's getting smaller, and nothing else is going on. So she decided to go to the Mayo Clinic. They discussed possible potential therapies at this point in time, but they also agreed, and the patient agreed, that they were okay with observation at this point. So this is ongoing. There's still some FDG avidity in the periaortic lymph node, but the patient doesn't want to do anything, and there's no role to take her back to the OR at this point, or more chemotherapy. So finally, in May, it's totally resolved, and that stays until today. So she was diagnosed in January 2011 with a 20% survival rate, and is now, at 5 years, is now 8 years out with no recurrent disease.